hematuria, acute kidney injury, the splenic sequestration syndromes, complications of AVN, hepatobiliary complications, and problems with leg ulcers. So the assessment from top to toe would be the standard observations using whatever local recording tool you have. We use Muse in at SWB. And some of the key things to point out would be any fever. Now, bearing in mind we are just, we still have, COVID present. A low-grade fever, less than 38, can accompany an unrecorded vaso-occlusive crisis, but certainly anything 38 and above, should be screened for sepsis. Hydration, we know hydration is important for the patient, so a record should be made of that. And the key areas that I would expect someone to listen would be to examine, would be to listen to someone's chest and to have to palpate the abdomen looking for hepatomegaly, splenomegaly. For some patients, there may be a degree of hepatomegaly that's normal for them, then the patients would know that. And some patients, especially those with the milder types of sickle, may have a residual spleen. So they would know if their spleen is normally palpable. So if somebody comes in acutely unwell, with clinical symptoms of anemia and shock hypertension and a new spleen, for example, those could indicate things such as a splenic sequestration. A full CNS examination, again, that could be quite tricky if somebody's in quite a lot of pain but would be important if somebody has presenting signs to suggest an acute stroke. And then there are other patients who would have like an indwelling central venous access device, such as a Vortex port or a Portacat. Very rarely, some patients may have lines, and leg ulcers as well could be potential sources for infection if a patient isn't well. So what investigation should we be doing? So full blood count, and bearing in mind we have to refer back to the patient's baseline hemoglobin. So from top to bottom of that table just gives you an example of what an average hemoglobin is. So lower for hemoglobin SS and then SC at the other end of the spectrum where the anemia can be mild. And most times there may be a historical record of hemoglobin, and in some cases the patients would know their normal baseline hemoglobin. So we always interpret that accordingly. So if someone whose HB normally is 60 presents with an acute anemia with a hemoglobin of 60, one of the key adjuncts that we use is a reticulocyte count, because if you drop your hemoglobin, your reticulocyte count should be increased, trying to compensate for that anemia. So if your reticulocyte count is quite low and you have an acute anemia, there could be things like parvovirus, say for example, which we need to consider, or drug-related causes. So I'd always refer back to what the baseline hemoglobin is. And likewise, we check renal and liver function tests, and the patients would normally have a baseline bilirubin. So recently, there's a gentleman who presented with a bilirubin level of 780. Clearly, that is much higher than any baseline, bilirubin level present. And going further forward, when we are all on the same pathology system, we'd be able to see patients' results from across the Black Country territory. A CRP, so a mild increase in CRP could be seen in an otherwise straightforward crisis, and I mean something less than sort of 30, 40 could be just in keeping with a sickle crisis, but certainly anything in the hundreds, I would screen for infection. And I would always make sure we do a group and screen when the patients present, because if they run into complications later on, at least we have a group and safe sample that's in place. A sepsis screen if there are elements of sepsis, and if there are changes to suggest a virus, or be it parvovirus, say for example, or somebody with acute hepatitis, then viral serology if appropriate. And one question we ask is, should a chest X-ray be done? And One of my young patients has had about 62 chest X-rays in her time, and I think it should only be done if you're worried about a chest sign. So if there are no chest features and normal saturations, then it is completely unnecessary. And likewise, an ABG. So, we know this is quite painful. I mean, so unless there was a concern about a chest crisis or hypoxia, then I wouldn't necessarily recommend patients having an ABG. And X-rays of the limbs. So this is really only useful if we are suspecting bony injuries, such as a fracture. You guys are the experts with that. Or we are suspecting something such as osteomyelitis. But for straightforward pain, X-rays of the limbs are really not helpful and unnecessary investigation. So if I just talk a bit about sickle pain, because this is the thing that most commonly presents with the patients most commonly present. So we can see here that on this chart there are different phases of pain. So leading up to a crisis, so the patients usually feel a crisis coming on. So in the initial phases, which may be a day or two before presentation, they would start using their oral medication such as a paracetamol, a non-steroidal, or a wake opiate. But they tend to hit ED when that pain is really established. And I will completely say the patients only come to ED as a last resort. They absolutely prefer to do anything else other than come to ED. Now, some of the patients who are known to us would come to us in our sickle cell center here, but that is open 9 to 5, Monday to Friday. So, and a lot of times the pain is out of hours, particularly in the early phase, in the early morning time. So most people would have tried simple pain relief at home, and therefore we would use opiates. Now, I know I am working with some of the team on some guidelines for ED, and it's in my list of things to do. But the analgesia would be as per local guidelines, and that probably would be morphine for the majority of patients. The national standard set by NICE, which the majority of times is difficult to achieve, is 30 minutes to the first dose of a sufficiently potent analgesia. So it doesn't tell you what, it doesn't tell you how, but it just says we give pain relief within 30 minutes. And there is really good evidence that suggests that if you really get on top of pain quite quickly, it can shorten the duration of that crisis. So what pain relief do we use? So I would always make sure we prescribe the regular oral stuff, the boring stuff, regular paracetamol, regular non-steroidal unless it's contraindicated. And then for our patients, we tend to use dihydrocodeine or tramadol, regularly in addition to the parenteral opiates. And for most people, morphine is the first option. So there is some debate about whether we should give morphine IV or subcut. The area under the curve is exactly the same. Clearly, an IV dose, the boost is quite high, and there are certainly some patients who prefer IV morphine, and we have become a bit more lax about this. But if somebody comes into ED and they're rolling around with pain, and we know that patients with sickle cell disease have really difficult venous access, the last thing we really want is somebody to be really having multiple goes at putting in a cannula to give pain relief. So if venous access is easy, straightforward, and morphine is a preference, and yes, IV morphine, I think as I said, we've become a bit more relaxed about that, but subcut morphine is equally effective, and we may initially give extra doses. So according to the patient's weight, if somebody is less than 50 kilograms, we can start with 2.5 to 5 milligrams of morphine. If somebody is not opiate naive, then 10 milligrams, initially reassess after half an hour, and then give an extra dose if needed. There are some patients, particularly those who come from London, who have alternatives, who are truly morphine allergic, and then their drug of choice is oxycodone or fentanyl, and that is often difficult to source, especially in the middle of the night when these may not be stock items in your pharmacy. Pethidine, good old pethidine, is only for named patients only, and the reason for this is for a safety reason. So IM pethidine can cause micro abscesses and muscle fibrosis longer term, and can also cause seizures because the metabolites accumulate in renal impairment. So it's only for named patients only. I think if you're really stuck and and there is nothing else, and the patient say that morphine, pethidine is what works for them, then I think that's what you do initially until we try to find something else that is more suitable. So PCAs, I do not think that they should really be set up in ED because people who put up PCAs, should really be familiar with using PCAs and be trained for their use. This may be something if somebody's admitted for the acute medical unit. And then, it's a constant reviewing the efficacy, and the principles of pain are the same as for any other patient. Very often people come in, on Entonox, and they are attached to the Entonox cylinder. It is said that an inhalation of Entonox has about, 5 to 10 milligrams morphine equivalent, and we know that there are longer term side effects. So really for the ambulance use only is where I would recommend Entonox. And then as anybody having opiates, then I would assess for toxicity by monitoring the saturations, pain score, sedation score, etc. And we have very few patients and none in the region who are truly opiate seeking. And I think we have become much better at recognizing these patients. So if someone comes to you in pain, they generally have pain. Right. So as I said before, the time to analgesia is a bit of a challenge, and I don't admit to us getting it right at SWB, and I would really encourage help from colleagues in ED. We know it's complete mayhem in ED. We know that things are really busy, and being able to give pain relief, and then who has the keys for the CD cupboard and all of that, how we realistically achieve this 30-minute target. And you can see here the top line, the top squiggle is our day unit, where we are trained, and we have the staffing to be able to give pain relief. There are times when we still don't get it right, and then in ED where it is a bit of an issue. So other things now, hydration. If a patient can drink, then IV fluids isn't needed. But clearly, if somebody's dehydrated, vomiting, diarrhea, then a cannula then IV fluids is reasonable. Cannulation in the feet, please avoid doing it as much as possible unless there is a critical reason why it must be done. The patients with sickle are prone to get leg ulcers, and that can cause a lot of morbidity for up to 2 years for the time it takes an ulcer to heal. So unless somebody is septic and there really is nowhere else to put a cannula, then I wouldn't put cannulas in the feet, and we counsel our patients to resist that as much as possible. Oxygen support as any other patient if there's hypoxia, and of course VTE prophylaxis is straightforward. So what else presents the ED? And I will talk a little bit about some of these things today. So transfusion reactions, if somebody is having a delayed transfusion reaction, they may come to ED with pain that mimics sickle pain, and then patients who have an indwelling venous access device, complications could be a thrombus or infection. Sepsis, we should all be familiar with sepsis. An acute sickle chest, drug side effects, hepatobiliary complications, priapism, PE, DVT, and stroke. And I'll talk a little bit more about these later on. So that year, the initial chart I showed you for the complications of sickle. So this is in our hospital that year, where the patients had sequestration syndrome, so a large liver, a large spleen, and acute anemia. 1 person had a stroke, 4 had chest crisis presenting to ED, 1 had hyperacute avascular necrosis, gallstones, one had something called hyperhemolysis, which is a transfusion complication, PE. Okay, so a little bit more about those. As we said before, this low-grade fever, and the reason that the patients are more predisposed to infections with sickle cell disease is because they are functionally asplenic, particularly those with HBSS, and there is something to do with the innate immune system as well. So the potential sites for infection are chest, urine, hepatobiliary, osteomyelitis, infected leg ulcers, or an infected port. COVID, of course, unfortunately, the uptake of vaccinations is not great in our patient group, and it's somewhere sitting around 40 to 50%. So a lot of patients are not vaccinated. And sepsis 6, again, this audience are quite familiar with that. So this is just an illustrative case for a young man who came to hospital. This was just before Christmas, and he had a fever of 39. So we know it's not sickle, and pain in his shin that did not feel like sickle pain. And the pain had been there for 4 days. He had a CRP that was significantly elevated. Because of the atypical nature of his pain and his fever, we did some plain x-rays which were unremarkable, but then he went on to have an MRI which showed osteomyelitis changes in keeping with osteomyelitis all down his tibia, and he had 6 weeks of antibiotics. So patients who present with shortness of breath, is there anything to suggest sepsis? Do there any features to suggest in keeping with PEs? There is an increased background risk in sickle, about 2 to 3-fold. And then, if somebody has been in hospital, or if they've been unwell and they've been lying in bed for a period of time, or if they've had COVID, then anything to suggest a PE. And a chest crisis. So what is a chest crisis? So that is a leading cause of mortality and can be recurrent. Usually, the majority of adult patients present after they've been in hospital with a vaso-occlusive crisis, but very rarely people will present to ED with a chest crisis. So those people at highest risk will be those who've had an operation. We are planning operations, so this should be reduced. Also, people who are in the 3rd trimester of pregnancy. The chest crisis is a syndrome of fever, shortness of breath, tachypnea, tachycardia, and an increasing oxygen requirement, because what it is involves, something sets up an inflammatory response in the lungs, and then you have this sickling in the lungs, or the sequestration syndrome in the lungs. So this rapid influx of sickle cells in the lungs causes a rapid deterioration in oxygenation. So the respiratory rate goes up, oxygen levels go down, the patients look really ill. They are coughing up bright yellow sputum, which I think is on my next slide, and it can be really rapidly progressive. So the key thing is just to have an index of suspicion. For adult patients, the signs are usually bibasal, but then can be multifocal, and very often the signs may be present, but a chest X-ray change might lag behind the clinical signs. So this fluorescent yellow sputum, this is what it looks like. And the reason it's bright yellow is, if you have red cells sequestering in your lungs, and you have your macrophages in your lungs breaking those red cells down, then your hemoglobin sort of breakdown products like your bile pigment tend to be really bright yellow. So it's a really characteristic looking sputum. And these are some chest X-ray changes for a patient who presented initially with a normal chest X-ray, and then within about 48 hours had full-blown infiltration. Hers was just on the left side, and she was promptly treated with an exchange transfusion, antibiotics, and was discharged home from ICU. All right, so other things that will present, and I'm just giving you a flavor for these things so that you can signpost to either your hematology team or to the acute medical team. Gallstones are quite common. They tend to, if we screen the majority of people with sickle cell disease, some will have about 50–60% will have gallstones at some point in time. They tend to be multiple small pigment stones, and can cause all the classic gallstone complications, cholecystitis, cholelithiasis, gallstone pancreatitis. The bottom picture and the treatment for those complications are the same as anybody else. And then there's one really important complication just to be aware of, and that is something called intrahepatic cholestasis, which loosely means sickling along the biliary canaliculi. And we've recently had a patient from Dudley who presented with a bilirubin level of 780. So this was a man who lived in the region for a number of years and didn't seek any help. And so we don't really know what his baseline is, but clearly 780 is quite high. And this, we can see from this chart, that is not his, but from another patient, you know, we have an acute episode, we treated it, resolved, and then we've had another acute episode, and for this man with a really high bilirubin level as well. And that intrahepatic cholestasis can make people really poorly with hepatorenal syndrome, confusion, encephalopathy, really, really ill, and they need to have prompt intervention quite quickly. So that will be something that you'll be speaking to your hematology team or either us at SWB. So priapism, some men present with priapism, and we've had a young man again who lives in the region who's really been struggling with priapism. So it's a prolonged unwanted erection, tends to happen middle of the night, first thing in the morning. What should we do for these patients when they come to ED? So it's extremely painful, so analgesia. We should be putting up some hydration. We should ask the patients if they haven't done any exercises like, you know, for a Steele syndrome. So what you do, you try to get them to either jog on the spot or, you know, some people walk up and down, because if we generate exercise, what you can divert blood away to, like, you know, your muscles, the blood vessels in your exercising muscles, to call it Steele syndrome, and that can achieve detumescence in some patients. But they may have done that by the time they come to ED. And we tell the patients, you know, if you've had priapism for an hour, rock up to ED, because if it's going to settle down and you reach ED and it's settled, fine. But if not, those patients may need to have penile aspiration. The longer a priapism goes on for, the higher the chances are that they will have erectile dysfunction. And we can see at around 12 hours of presentation, there is about a 92 chance of these young men in the prime of their lives having erectile dysfunction. So it really needs to be, managed as soon as possible with the help of the urologists. So acute stroke, so the acute neurological presentation, so, you know, bacterial or viral meningitis, stroke are common, and usually the ischemic stroke tends to be mostly a phenomenon in childhood, and then you have a peak later on in life when the other risk factors such as diabetes and hypertension come into play. But in the 20s and 30s, then there's a risk of hemorrhagic stroke from multiple aneurysms. So the management would be as per the stroke team with the involvement of hematology. Some of these patients may need to have an exchange transfusion. And just to give you a flavor of why they have stroke, is usually around the circle of Willis. And the bottom right, we can see so the cerebral arteries sort of tailing off quite abruptly at both ends. So this patient has bilateral carotid artery stenosis, and then distal to that area of stenosis, you have moya formation, which is like these new blood vessels. It's called moya because it's supposed to be like a cloud or a puff-like collection of blood vessels, and they're quite fragile. They don't have the normal structure as blood vessels that would have, and they can burst and bleed and can cause the hemorrhages. So children now should be being screened for stroke. The incidence is reduced, but very often, even some of these patients who are on adequate treatment do have still end up having progressive cerebrovascular disease. So it is one of the emergencies in sickle cell disease, treated promptly with an exchange transfusion to help preserve oxygenation and to reduce the pathology, which is sickling. I think I alluded to acute anemia in my earlier presentation. So I said, you know, you referred to the based on hemoglobin, so that the anemia might result from an increased hemolysis. So say, for example, somebody who comes in with sepsis may have worsening hemoglobin, but in that case, the reticulocyte count is going to go up. Patients who are uh, on on various medications such as hydroxycarbamide, if we give them too much of a dose, that can cause anemia, can also cause other types of other cytopenias. The sequestration syndromes, a big liver, a big spleen, particularly in children, also seen in the patients who have an intact spleen and can cause almost like a shock-like state with a rapid fall in hemoglobin. And we often tell, I'm an adult physician, but for kids who come to, for children, that their parents can feel for a lot for a spleen. So if a child comes being pale, being unwell, and who has a massive spleen, then they need to have a transfusion sort of fairly promptly. Sequestration, a splenic sequestration can actually cause people to, especially in children, to potentially demise before coming to hospital. Red cell aplasia from parvovirus and delayed transfusion reaction, and the history here would help with that. So when do we transfuse? And really only your hematologist should be making that decision. And there are really specific, and the reason for that, there are really specific indications. As I said, everybody has a unique degree of anemia. And there are some really specific complications of transfusions that the patients have. The rate of antibodies is about 30%, and then there is something called hyperhemolysis, which is where the patients destroy the blood that they transfuse, they destroy their own blood cells, and it can be quite catastrophic. So for that reason, we limit transfusions to certain things. So in an emergency situation, it would be for severe acute anemia where a patient is symptomatic, parvovirus, splenic sequestration, for example. For an acute stroke, an acute chest crisis, for those patients who are really acutely ill, then an exchange transfusion that is arranged by contacting us, and there are networks to help with that. And ultimately, when I get myself into gear, I will do this as a quick guide that you can put up in ED so that somebody can refer to this for quick guidance. Now the patients tell us that very often they are faced with this all the time. So some of the patients' voices are, "We are not drug seeking, we are not drug addicts. I'm not just a sickler. I also have, we have doctors who have sickle cell disease, patients who have their families, their authors, who have sickle cell disease. So we have a very, some of our patients are very high achieving, and I'm not aggressive, but I'm in a lot of pain. So therefore, I can't be nice and quiet and polite because the pain is driving me out of my mind. And sickle cell affects everybody differently. And the patient say, you don't have to know everything about sickle cell disease, but just listen to me and listen to, what I need for when I come to ED. And so an illustrative case, if I just sort of bring all of that around. So this is somebody in our hospital. So she was a trainee barrister. She's normally cared for out of region. She was visiting friends and family, came in on a Friday night, and the pain was really typical for sickle pain. She had 5 milligrams of morphine in ED, and then kept asking for pain relief. So I know we're moving into the acute medicine group territory now, but the history we were handed over. Oh, can you see this patient with sickle? She's opiate seeking. She's keep asking for morphine. So when we, so she was prescribed morphine 2.5 to 5 IV every 6 hours. She had no venous access. So how are the nurses going to give her, her morphine? And they posted water and said, well, let's transfuse her. But then they didn't do that because, and I couldn't really see a reason why, because she had no venous access. So the patient was a really good historian. Her sickle cell disease has caused her quite a lot of trouble. She said, she doesn't necessarily need IV morphine. Subcut morphine works just as well. She normally has 10 milligrams of morphine when she comes in. When we looked at her hemoglobin was a regular hemoglobin, so there was no reason for her to have any blood. And she'd also had a temperature of 39 overnight that hadn't been acted on. So I'm not saying that we are the end all and be all. We get it wrong at SWB as well, but these cases are just for us to learn from things that could go better. So, the take home point is, if we had spoken to her 10 milligrams, she would have had that, and if it had been subcut, she would have been, much more settled by the time we see her. So she came in on Friday and she had not had adequate pain relief all weekend until Monday. So really that wasn't good enough. There are some guidelines, and very soon our website for the network should be up so that we can access those guidelines there. And then there's the national standards, which are from 2018. And I'm happy to take any questions. And I think this is your feedback QR code. So any questions, anything anybody would like me to clarify? No questions? Okay. So if there are no questions, I just wanted to end with saying thanks very much for having me, and I'm happy for you to share the slides, and any feedback would be most gratefully appreciated. Thanks so much, and I hope today is uneventful. Bye.